Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Nick Mudge here. Welcome to Top Med Talk. This piece is taken from the 8th Australian and New Zealand Symposium of Perioperative Medicine Special Interest Group. Updates in Perioperative Medicine 360, which took place between November the 7th and the 9th of 2019. This piece is presented by Professor Alison Mudge, Conjoint Professor of Medicine at the Royal Brisbane Clinical Unit Faculty of Medicine, and Gideon Caplan, Associate Professor of Geriatrics at the Prince of Wales Hospital in Sydney. This is part 2 of a 2-part piece.
Thank you, Alison. And yes, I can endorse the Delirium Association meeting. It's an excellent meeting. And I should also disclose that I'm president of the Delirium Association. And I'm also a deliriumaholic, but I'm not recovering. So I disclose that too. But delirium is an extremely important topic, and I want to briefly acknowledge my collaborators, and you can't get anywhere without having a team of people working on the problem. And delirium is a huge problem. Alison mentioned that delirium is expensive for hospitals. We recently published this study, which was done in collaboration with Deloitte Access Economics, that shows that there are over 130,000 cases of delirium each year in Australia. That means there are more cases of delirium than there are myocardial infarctions. There are more episodes of delirium than there are strokes. Now, we'll just do an audience poll. How many people work in a hospital with a heart attack unit, with a coronary care unit? Anyone? How many people work in a hospital with a stroke unit? How many people work in a hospital with a delirium unit? Not many. So delirium is a national emergency because there are so many cases, and because it is increasing as the population ages, and also because of the operations we can do on people and the drugs we can give people that induce more cases of delirium. And we really need to bring to the attention of administrators, health department bureaucrats and politicians that delirium is a national emergency that needs to be better addressed. And as you can see, we calculated that it's costing Australia alone, this is not the world, this is just Australia, $8.8 billion a year. And this is without having treatments that cost $60,000 a patient like the oncologists have, or the other, the surgeons can do operations that cost even more than that. We don't have expensive treatments for delirium. This is all the cost of the illness. I'm sure we could bring down the cost if we had a treatment for delirium. And studies which have looked at interventions that do reduce delirium show that it does reduce the cost. But this is an emergency that we're all responsible for because we're interested in delirium. So I became very interested in delirium to try and work out what was causing delirium. And this is one of the confounders, one of the strange things about delirium, that we've known about delirium for so long. It was described by Hippocrates, but we still do not have a single treatment for delirium on the pharmaceutical benefit scheme, nor on the FDA. It's not Australia's fault. There is not a single treatment for delirium. Yet we've known about it for thousands of years. So we've been derelict in our duty in not researching delirium, I feel. And that's possibly because delirium is very complicated. As John Donne would have said if he'd known about delirium, no, delirium is an island. It's connected to all these other conditions. We know that delirium occurs in the context of all these other illnesses and is associated with them and linked to them. And so it's very hard to separate delirium out from all these conditions. And so we need to do studies with multiple control groups to try and adjust for that. Or we need to have all those groups in the study at the same time so that all the other signals from those other diseases become noise. One of the traps of delirium research is just studying a group of patients purely with one diagnosis, because then you get a massive signal from that diagnosis, whatever that is, if it be that surgery or a certain type of infection. You could get a massive signal from that illness, which makes it hard to find whatever signal there is from delirium. Because we don't know what's happening in delirium, there are many, many theories, and these are some of the most popular. And we certainly know that all of these things can cause delirium, or delirium can happen in all these conditions. We know that people with an infection can get delirium. It doesn't even have to be an infection in the CNS. Obviously, the bladder infection can cause delirium. We know that drugs that affect neurotransmitters can cause delirium. Physiological stress alone can be enough to cause delirium, and electrolyte disorders or renal failure can cause delirium. All these things can cause delirium, but which one of them is actually the final common pathway? That's the thing that's hard to know. There's been a lot of work looking at the first 5, and none of those studies show any link, any association between the severity of those insults and the clinical markers of delirium at this stage. The most popular theory, though, for many years has been the inflammatory theory of delirium. And there's no pointer, is there? No, I don't think. But the inflammatory theory, so this is looking at someone's, on your left, the young person's brain, which has no underlying damage from dementia or any other conditions, and it posits that when there's an inflammatory stimulus in the periphery, that crosses into the brain and activates microglia, but then that activation of inflammation in the brain is damped down and they don't get a prolonged or any delirium. It's insufficient to cause it. But in someone who has a damaged brain, most commonly because of dementia or some other insult, but most commonly dementia, that you can get persistence of the inflammatory insult in the brain. It becomes self-perpetuating, and certain inflammatory cytokines will arise, TNF-alpha, interleukin-1 beta, and interleukin-6 particularly are mentioned in the theory, so I want you to remember those 3 markers, TNF-alpha, interleukin-1 beta, and interleukin-6. There'll be a little test later. And that leads to permanent overactivation of microglia, which then damages neuronal cells and causes more severe, more prolonged delirium, and eventually then leads to permanent cognitive dysfunction, permanent ADL dysfunction, all the harms of delirium. And you can show this very nicely in mice. So on the left, you've got a mouse who's got a normal brain. They've been injected with normal brain homogenate, that's NBH, and then they're injected with lipopolysaccharide into their peritoneum, which simulates a urinary tract infection. And they get a little bit of activation of their microglia in the top slide, but not much interleukin-1 beta in the bottom slide. But the mice who have ME7, which is a prion condition which causes dementia in mice, they get, you can see, much more activation of their microglia, and that's just by itself. They've been injected with normal saline, not with lipopolysaccharide. On the right-hand column, you've got the mice who get the prion dementia and then get insulted with lipopolysaccharide. And they get more activation of their microglia and an interleukin-1 beta response that you can see in the bottom slide. So you can clearly see this inflammation in the brain with a peripheral inflammatory insult. But is this an association or is this causing delirium? Well, let me go one step further. You can show that they do get a cognitive deterioration on a cognitive test that you can do on mice. And you can't do the 4AT on mice, but you can put them through a maze test, and it shows that the mice who get the ME7 prion disease and then the lipopolysaccharide injection get a temporary decrease in their ability to complete the maze test. And that looked all hunky-dory, that it looked like there's a beautiful theory showing up here that inflammation in the periphery can cause inflammation in the brain, which causes cognitive dysfunction. But then, as a result of our work, which I'm going to show you a bit later on, these researchers did one more study, which is because the dirty little secret of lipopolysaccharide is that it causes, as well as causing inflammation, is that it causes hypoglycemia systemically. So you can see that mice injected with lipopolysaccharide, their blood sugar, the blood glucose level drops. Okay? And then on the right-hand side, you can see that there's two groups given lipopolysaccharide. In the continuous blue line, they're given lipopolysaccharide and saline. In the dashed blue line, they're given lipopolysaccharide and glucose as well. So that prevents them becoming hypoglycemic, and you can see that they don't get as much cognitive impairment when they don't get hypoglycemia. So a lot of the cognitive impairment that was put down to neuroinflammation is actually due to peripheral hypoglycemia. This is studies in human CSF looking for these markers of neuroinflammation in delirium that I mentioned before, and I'm sure you all remember them, so I'm not going to test you. The interleukin-1 beta, TNF-alpha, and interleukin-6, as well as I've thrown in interleukin-8 as a bonus because you're such a good audience. You can see that there's no clear signal in studies of humans with delirium for any of these cytokines. So there's not a clear inflammatory signal in the brain that inflammation is perpetuating or causing delirium. So we're going to leave inflammation at that point and move on to our work. So we were looking initially for markers of cell death, and we did this experiment after looking for multiple markers of apoptosis, couldn't find anything. So we looked at non-specific markers of cell death, which are lactate, neuron-specific enolase, and S100 beta. And if cell death were happening during delirium, then all of these markers should be elevated during delirium. But what happened, we found that lactate was elevated, S100 beta was unchanged, and neuron-specific enolase was decreased. So we're trying to understand what that means, and we're not 100% certain, but the most economic explanation, because neuron-specific enolase, I'm sure you'll remember your biochemistry from university, neuron-specific enolase is an enzyme in the aerobic glycolysis pathway. It's the last enzyme before you get to pyruvate. So this suggests that there could be a suppression of normal aerobic glycolysis and an increase in anaerobic glycolysis, leading to more lactate. And we found that the level of lactate in the CSF in delirium correlated with outcomes of delirium. For example, people who died during that index admission when they had delirium had a higher level of CSF lactate than people who went home. We also found that the decline in activities of daily living function over the course of the admission with delirium was correlated with their CSF lactate level. We also found that their severity of acute illness, as measured by the Apache score, their severity of delirium, as measured by the extended version of the CAM and by the delirium index, was correlated with their lactate levels. So it was clearly more linked to the clinical condition of delirium than the inflammatory markers. Most interesting for me is that now a study of patients in Oslo that have delirium compared to patients that don't have delirium, who have a hip fracture, has also shown in the middle that people with delirium in Norway also have elevated CSF lactate. So this is the first validation of our finding that CSF lactate is elevated in delirium. So we wondered, how else can we look for changes in glucose metabolism in the brain during delirium? And if you can lumbar puncture people, then you can scan people. So we started a study using FDG PET to look at glucose metabolism in the brain during delirium. For those who are unfamiliar with fluorodeoxyglucose PET, it measures glucose uptake because fluorodeoxyglucose is an analogue of glucose that can be taken up into cells but not metabolized. It's attached to an isotope so you can see where it's been taken up. And you can, when you have a PET CT scanner, you can very precisely work out what parts of the brain are less metabolically active than others. We know that FDG PET is used widely in dementia, and you can tell what kind of dementia people have from the patterns of glucose uptake in the brain. And you can also tell, before people get dementia, who's going to get dementia, and you can tell people with MCI who's going to progress to dementia. So it's actually a much more accurate test than looking at amyloid PET scans in terms of working out the severity and the prognosis of people's dementia. Now, I'm moving quickly through this just because there's a lot of material to cover, but what you can see is on the right you've got a normal brain, and so the light colour shows where there's more glucose uptake into the brain. So you can see on the normal brain on the right there's a symmetrical pattern of glucose uptake into the cortex. Most of the glucose is consumed in the synapses. The brain uses 20-25% of the glucose in the body, so it's a very metabolically active organ. And you can see there's this lovely, even bright colour around the cortex in the normal brain. Whereas in the delirium brain on the left, you can see the symmetry is not as good. And if I had a pointer, I could really show you much better. But there's an area of what looks like increased uptake, or it could be preserved uptake, which is the sensory motor cortex in the delirium patients. I'll show you some other scans later. But you can see, especially at the front of the brain, the frontal lobes, there's hypometabolism of glucose, but also to a certain extent the parieto-occipital and the temporal lobes too on the lateral views. This is a different patient with delirium. Has worse hypometabolism, but you can still see relatively preserved glucose uptake into the sensory motor cortex. And we scanned about half these patients after their delirium resolved. This is about 3 months after they'd left hospital, when their delirium scores had all normalised and their FDG PET scans improved, but they didn't come back to normal. So they still had hypometabolism 3 months after their episode of delirium. So their brain had not come back to normal, even though their delirium scores were normal. We don't know, because we don't have pre-illness cognitive tests on these patients, whether their cognitive function had come back to normal, but their cognitive function had improved compared to when they were in hospital. So this is yet another patient who incidentally we found had a pituitary adenoma, but you can see there's hypometabolism across the cortex, which improved 3 months after the delirium resolved, although it's still not back to normal. You wouldn't want your brain to look like that, believe me. And we thought, this is amazing, but first of all, we didn't understand why it was so widespread across all the cortex, and we weren't sure if that was correlated exactly with the clinical symptoms of delirium itself. And also, we know that there is an effect on cognitive function of just being sick. One of the reasons why we have sick leave is to take time off when we're sick, because we can't think as clearly as we can when we're well. So illness itself does have an effect on cognitive function without getting delirium. It causes all of these changes without getting delirium, which can affect FDG PET imaging. So we weren't sure if the previous scans I showed you were really the signal of delirium alone. So we recruited a group of patients, and at this stage we're now up to 10 in the delirium only, 10 in the controls and 20 in the DSD. But you can see they're quite well matched for age, but you can see that the delirium groups have worse cognitive function. The control group in this study had no delirium and no dementia. That's both on history and on their IQ code. And we found, so the top is someone during delirium, the middle is the same person after the delirium is resolved, and the bottom is a person who's sick in hospital, in ICU, but doesn't have delirium or dementia. And you can't tell exactly from that, but their scan is not normal. So when I show you, their cortex is a bit ragged compared to a normal person. So they've got some cortical hypometabolism of glucose, but not as bad as the people do when they have delirium. So what we did is subtract the people with delirium from the sick controls to see what is the actual delirium signature, which are the parts of the brain that are only affected in delirium, not in routine illness. And we found the ones that are mainly affected are the right superior frontal, the bilateral thalamus, posterior cingulate, and these parts of the brain make perfect sense because obviously the frontal lobe is very important in executive function and is part of the default mode network as well as the cognitive control network. And people who have lesions of the right superior frontal cortex are known to be more impulsive. The thalamus sits at the top of the reticular activating system, so it's very important for consciousness as well as integration of signals from all parts of the cortex. The posterior cingulate cortex is a major part of also the default mode network and has previously been shown on MRI studies to be affected in delirium in terms of blood flow as well. We also found there was decreased glucose metabolism in a small part of the temporal lobe that's important for semantic memory, and the left superior parietal cortex. So there is a signature of delirium which is not as dramatic as the initial scans led us to believe. But these levels of hypometabolism correlate very closely with our clinical measures of delirium. So, for example, looking at the delirium index, which is a measure of delirium severity, and glucose uptake in the thalamus and the superior frontal cortex, you can see that it's quite a good correlation. And we can do this for all different parts of the brain. So also the superior frontal cortex and digit span forwards correlates very nicely on the glucose metabolism. Working memory, which is a combination of attention, processing speed and memory, correlates well with glucose uptake in the superior frontal cortex, and mental control and glucose metabolism in the thalamus. So on these bedside neuropsychological tests, we can show that the changes we're picking up on the FDG PET scan correlate quite closely together, which leads us to believe that what we're finding is likely the final common pathway of delirium. We won't know until we intervene in this pathway and see if we can change the course of delirium. But we suspect that all of the other factors, the inflammation, the disturbances of neurotransmitters, and so on, feed in through cerebral hypometabolism to delirium. But it's only if we can modify that cerebral hypometabolism and change the course of delirium will we be able to confirm this. Because obviously we can't induce delirium in people to see if this will, by affecting this pathway to see if that is the case. You can do it in mice, but not in humans. So I'd strongly support you coming along next year to the Delirium Association meeting. We're going to have about 10 overseas speakers, very eminent, both medical nursing from North America, Europe, England, very wide spectrum of speakers, and it's always an excellent conference, if I say so myself, and I have been to all of them, so I have some expertise.
I think that might be morning tea time. Thank you very much for your attendance.
Top Bed Talk.
Nick Majerison here. Have you got yourself onto edpom.org yet? If not, you might not be aware, EdPom Chicago tickets are free for a limited period only. Go now to edpom.org. Evidence-based perioperative medicine. edpom.org.